Okay, cool. All right, we are going to finish up finally the retreatment stuff with the separated instruments. We kind of started it, but we ran out of time, and then we will jump into the how to actually read papers and how to use AI. And I did get approval from Rhodes that I can teach you guys how to use ChatGPT, not to cheat, but to actually learn more effectively. So when we talk about separated instruments, I know this is a little bit of a repeat from last time, but I like to be complete. It actually says it's like 3 to 5% incidence in the literature, which seems insane. That means 1 out of every 20 cases you're breaking a file. I don't break a file a week. That would be insane. So this is from a study which was in a postgrad program. I think that's why it's that high, but that still seems really, really. Don't break files on 1 out of every 20 cases, you guys. That's crazy high. Now, for most of those cases, what they looked at, it's mostly lower molars. Maxillary molars are the rest of them. And the higher it is, the easier it is to remove. The question, though, isn't do you have to remove them? It's really, should you remove them? And what you need to kind of look at when it comes to removing the files is how much damage are you going to be causing by removing them? And when you look at it, the techniques really haven't changed much since this paper came out in 2005. In the coronal part, they're really easy to get out. You can get them out using burrs, you can get them out using lassos, you can get them out using ultrasonics. They're really easy to get out. You trough them out, they pop out. So in the coronal third, middle third, they're pretty darn easy to get out. 100% success there. When we look at the apical third, however, of the 34 cases, 9 of them they had success, 7 of them they perforated. So their conclusion was you really shouldn't try to get them out, especially if it is curved, because the risks are just so high. All you're going to be doing at that point is really fixing the x-ray. And what we see is that the prognosis doesn't really get affected that much by having a niti obturation versus gutta percha. If it's up high, for sure, get those out. They're easy. You guys will be doing this in practice. I do this probably once a month from dentists who break things. But if you're doing something and like you get around a curve and all of a sudden there's a file now as the apical fill, congratulations, they get a cool niti obturation. That's kind of how I would handle it. So what are the techniques? Cliff Ruddle's probably the first one who designed this. These are his files that you can get from Dentsply. You create a staging platform using either gates or piezos, so create a large kind of surface on top of the actual file, and then you use a series of smaller and smaller ultrasonics to vibrate it out. The problem with this is you really kill the tooth. There's no remaining dentin. And this is kind of how, if you've been to any of the AAE things, the Terauchi method is kind of the similar. Any of those removing files from the apical third, in almost all the ones that I've seen, and if you guys know of something else, or if anybody watching this knows of something else, please let me know. The way you get them out is you have to be able to see them, and to get around the corner, you have to create a line to be able to see them. So you kind of destroy the tooth to do them. The other problem, if you're removing metal, like if you're removing posts or if you're removing stainless steel files, you can go to town with ultrasonics on them. They pop out pretty reliably. It's not a problem. Niti, however, breaks when you put ultrasonics on them. Have you guys discovered this? If you've been trying to vibrate out nickel titanium, it will break. So you can hit it a little bit, and then all of a sudden, parts will break off. So you have to be very cautious when you're using ultrasonics on separated nickel titanium, because if you start to crank up the power, chances are you're going to take that small little bit that you've worked really hard to expose. You're just going to break that off. And now you're going to be stuck with a file that's now down and have to do all the work over again. So just a heads up, they do break more often than you think. So other techniques, this one works pretty darn well. The tube and glue, if you can expose about 2 to 3 millimeters of the file, you guys probably have. This is actually one I did in residency. This is a photo from residency that I did, where if you find a tube that will fit pretty tightly over the file, you can use dual clear composite, you can use super glue, you can use a headstrom to like file down next to it and like squeeze it in there. If you put that in there and let it set up, that's the hardest thing, is to just don't touch it while the super glue or the dual clear composite cures. it will cure up, and then you can literally pull it out. This is one of my favorite techniques to use when I'm able to get, if it's a long, like this, you can see this is a longer file that was separated. There's only like maybe 2 millimeters that I was able to grab onto here. This one was a dual pure composite that I put down inside the tube right here. But once it sets, it's pretty predictable to grab this and pull it out. This is a really good technique. So keep this one in your back pocket. This one you will use at some point in practice. And that's why having a bunch of different sizes of tubes is useful. So you want one that fits pretty snugly over these. Have you guys tried this at all? Has anyone tried this technique yet? Yeah. Was it successful?
Yeah.
Yeah. It works when it works. Like this is, if I can't get it, my first step is always to try to just see if it'll pop out by using, sometimes I'll use the Endo Explorer. I just try to like flick it out. Sometimes that will pop it out right away. Next step, if I can't get it out by flicking it out or hitting it like gently with an ultrasonic, is this. The Ruddle also has the instrument removal system, which is kind of similar. How this works is you can see there's a little notch right here. These are all different sizes. This is threaded. So you back this out, and this little kind of cannula in the middle lifts up. You have to expose enough of the file that this part right here will go through the file. The file will go through that little part right there. You then screw this back in and it locks in place. And the next like 5 different techniques I'm going to show you use this exact same idea. You can do this with spinal needles. So these are the needles that you use for like spinal taps or for blanking on blocks they give for when you're epidurals as anesthesia. There's ways to do this where you can buy these and you can modify it. These are other ways you can do it. They're very similar to this. These are a lot smaller than the Ruddle ones that we showed. So I found a couple of videos online. If you've never seen these before, it's kind of cool, but similar technique. You're just using a cannula on the outside with a small little needle on the inside that will lock against where the file would be, and that will pull it out. You can also use these really cool tweezers. Zumax actually makes these, and they're pretty cool how they work. They extend out and grab it. They are quite pricey, but I got to play around with those recently. These are pretty neat. But here's a picture of how that works when you've exposed the file like this. You can see they open like this, and then as you grab them, they're able to grab the file and you pull it out. So another cool tool to have in your back pocket. This is their version of the instrument removal kit. Similar concept, trephine burrs to expose the file. Once you've exposed it, different size tips that you can then use. You can see the little tweezer shaped things here that you then use to grab it. So most of these techniques are all similar. You're either going to get something down next to it to wedge against it to pull it up, or in this case, they have little clampers that you can use to grab onto it. Similar size here, you can see the different shapes that they use. So here are the tweezers. These are all the needle next to a cannula that you would shove in to like wedge against it to pull it up. Has anybody used a lasso technique before? I know this was Alexa's favorite. No? Okay. This one, there's lots of videos on how to make it, but you can use fishing wire. You can use really thin metal wire. But you make a loop, you thread it through the gauge of a needle. You can actually use you want it to be really, really thin. So you can use a 30 gauge like injection needle, just break the tip off so it's not sharp anymore. And you extend it out so the loop is exposed. And then once again, expose about 2 to 3 millimeters of the file. Get the loop down around the file so that it's like this. You then pull the loop tight and are able to pull it up. So this is an image of how that works. Another cool way, these are all similar ideas of how to remove the file. So there's lots and lots and lots of different techniques. Pick your favorite. There's just, once again, my goal is to have you all learn all sorts of different techniques. If sometimes you can't grab it, so in those cases, we got to bypass it. So really small files, start with the 6, get around it. If you get a 6 around it, you can get an 8. Sometimes you get a 10. Go back around it, 6, 8, 10, 6, 8, 10. EDTA can help. Be careful because sometimes you're going to create your own canal and cause perforations. So make sure you're pre-bending. Make sure you're matching the curve if it is around a curve. Sometimes if you're brave, you can actually get back around a broken file with another rotary file. This works well with K files. If you've broken a K file, you can actually get back around it with a rotary file. I will sometimes use the rotary file by hand. If I'm able to bypass it with hand files, I'll actually put a bend on the rotary file, use that to get to length, make sure that's good, hit it back up. This is where that M4 hand piece can be useful if you've used one of those before. The other one that works really well is if there's another canal. The number of times I've had a dentist break it off in the mesial lingual, and there's a beautiful missed middle mesial right there that goes right past the ML, and that's actually where the file broke. The file broke as the ML and the middle mesial joined. I can use the middle mesial, get all the way down, just leave the file. Who cares? It's entombed in gutta percha because you're fine. Same things with MB2s that join. I'll have that happen often if the dentist finds the MB2 and breaks a file in it. If I can, or if they find the MB1, but they haven't found the MB2, use the other canal and leave the file if it's broken in there. So if you know that they join up, don't worry about the file. Just find the other canal and use that one instead. Remember, you don't always have to remove it. Most of the time, if it is your file, the only reason you really want to get that out is because of your own ego. Okay. If it's up high, sure, get it out. They're easy. If it's really tiny, oftentimes you can just bypass it, pop it out. But if it's in a really bad place, the only reason you're going to be getting that out is to make yourself feel better about it. And you're probably going to destroy the tooth doing it. Okay. The other thing to remember is you can always do an apico. Okay. On apicos, which by the way, I don't know why I had like a recent spike in my apico view, so that was kind of cool. I really wanted to talk about retreating apicos because that's something we haven't really talked about. When do you do a second surgery versus when do you go back and redo the root canal? Good question. And my thing is there some untreated anatomy? Was there a problem with the initial surgery technique, or sometimes you have to do both? And so here was a case I did recently on actually a friend of my office managers. And you'll see in his case, he had these wickedly cool the amalgam retrofills. Do you guys see why this case is failing? Is that showing through?
Yeah.
Can you see it like shattered?
Yeah.
Yeah. So he has like fractured root fragments here. So even though, yes, it's not the prettiest root canal, and yes, we could make it better, the only thing that's fixing this is going in and redoing the apico. Because I had to go in and get those fragments out because that's what was actually causing the problem here. And I've seen him since for post-ops, and he's doing much, much better. There have been other times where I've had cases where they did an apico on like a maxillary molar. They missed the MB2 during the first treatment, the first orthograde treatment. They missed the MB2 on the apico. And I just went in and I just treated the MB2 only normally through the tooth, and that fixed all the problems. So sometimes when you redo the apico, you just redo the apico. Sometimes when you redo the apico, you just redo the root canal. And sometimes you have to do both. And so with everything, you want to look at why it's failing and figure out what you can do to make it better. And then the final thing I wanted to talk about, we had talked about modifying the factors that were causing the tooth to fail. I know this has been 3 months of retreats. I'm so sorry. This is supposed to just be 2 lectures, but we had a lot of really good questions. And we had talked about if you go back to before all these fun things have happened, we had talked about modifying the tooth to make it so that it would heal up, that the bacteria wouldn't be so bad. We had also talked about that case that I had where the patient was going to go through open heart surgery and how she was all of a sudden going to be at higher risk of having infections because she could be on anti-rejection meds and things like that. So how do we modify the patient so that they might be more prone to having a healing? Pretty straightforward. When we go back to that inflammation graph where we have patients who have low inflammation, so the high risk infection, or high inflammation, so the high risk of pain. Really, it's these things, and we've talked about this a lot. adjusting the occlusion, make sure you're adjusting the opposing. That's the most important thing that people forget. The dentist always adjusts the teeth they work on. They forget that that tooth that's opposing with huge cusp is a problem. Antibiotics sometimes do fix problems. They're definitely overprescribed, but I found that sometimes even the placebo effect is enough to break that cycle of pain. Steroids are really, really useful. We've talked about those before. Physical therapy exercises make a big difference if you can get them to stop clenching. Muscle relaxers give them a good night's sleep. Braces are, I'm recommending braces a lot more, and I'm getting a lot more people to accept them, probably because I'm in braces. My orthodontist is like, oh my God, you're sending us so many more patients now. But yeah, that's when you have braces on, they're like, oh, I guess it is acceptable to have braces when you're 40. And then the other thing to remember, calcium hydroxide, Vitapex, all that is great. It also lowers the inflammatory response. That's the other nice thing that it does, is it does reduce the inflammation outside the teeth. So that's, I do like using this on my kind of tougher patients because it lowers the inflammation. Finally, we're finally getting done with this. And then we get to go on to the fun stuff. Retreats are always unpredictable. Figure out why the tooth is failing, because if you don't know why it's failing, you're not gonna be able to fix it. Make sure you have a really deep toolbox. I gave you guys 100 freaking different ways to retreat teeth. You're not going to use it on everyone, but there will be at some point in 5 years that you're gonna be like, oh, I'm gonna need this. So keep all these ideas in the back of your head. You will someday pull them out. Be creative. That's what sets us apart as specialists, is we sometimes have to come up with some really creative ways to fix these things. And remember your goal of keeping the tooth asymptomatic and functional for the patient versus making the x-ray look pretty and, you know, your ego. And I do remember when I was in my first year, we had a grad from a few years prior come and talk about retreats. And one of the things they told me stuck with me is like, when you retreat teeth, the x-rays aren't going to be as pretty. It's just, you can't control what was there before. So who cares though if it's working? Because that's what the patient cares about. If you can give the patient a tooth that's still functional, they're going to be very happy. So keep that with you, and let's be done finally with stupid retreats. Any questions on those dumb little guys?
For that tube and glue method, could you also use that if you're like trying to get carriers out that are like stuck in there or something?
It works, but you got to make sure that you've removed enough of the gutta percha underneath that it is loose.
Got it. Thank you.
Yeah. Any other questions?